Bismillahir Rahmanir Rahim. Our session today is about taking a clinical history. I'm Dr. Abbas Abdulzahar Al-Hassani from the Department of Surgery in Basra Medical College, University of Basra. So, the objective from this talk is taking a few notes about some terminology, preparation for the approaching the surgical patient, and steps of clinical approach and clinical history, in addition to special cases in history taking. Now, there's very important two terms is going to be discussed, which is signs and symptoms, and it's very important to differentiate between the two. During history taking, healthcare provider shall report the problem from which the patient is suffering. This is called symptoms. So symptoms are problems from which the patient is suffer and should be reported in the patient words during history taking. While signs refer to during the clinical examination, healthcare provider shall report the clinical finding that give a clue toward the diagnosis. So signs is detected during clinical examination, while during history taking we report symptoms. It's important to differentiate between the two. Now we take an example for that: pain and tenderness. So pain is a subjective, distressing feeling often caused by intense or damaging stimuli. This is detected during history taking, while during examination, the painful site, once you palpate it, you detect there's a tenderness. So it's objective rather than subjective feeling. Now, before doing anything for the patient, we have to have some preparation. So you have to prepare yourself, you have to prepare your patient, and you have to prepare the environment. About yourself, you have to have a very good theoretical background about surgery, for example, and you have to be confident during confrontation with the patient and face-to-face situation in the clinical ward. In addition to that, you have to be well equipped with the tools you are going to use during a clinical examination, like sphygmomanometer, like stethoscope, thermometer, tape measure, and so on. So all of these things should be prepared, and you have to have these equipments during work in the ward, and this is important during daily clinical sessions, in addition to during examination and future career. Now, what about the preparation of your patients? The patient doesn't know you, and you come to the ward where the patient have to be asked about history and then to be examined. So the first thing to do is to greet the patient. The second, you have to introduce yourself. And the third, you have to explain the procedure, what you are going to do for this patient. For example, I'm going to take a history from you, or I'm going to do a general examination, and so on. So this is very important. The fourth point is taking the permission, and the permission during history taking and clinical examination is usually verbal. So verbal permission or verbal consent is important before uh, taking any notes in the history or progress in the clinical approach. The third most important things to be prepared during clinical setting is the preparation for the environmental conditions. Lighting is very important, so you have to have a good lighting, and it's preferable to be in natural sunlight if possible. Second is the temperature. You have to take history and examine the patient in a very good or as good as possible uh, environmental conditions, because too cold or too hot will break the patient cooperations, and in turn will affect the outcome of clinical examination and clinical history. And the third very important point is the privacy. You know, we are living in um, many social and religious restrictions regarding our community, so you have to respect that very well. So, particularly in the private parts of the body, you have to you have to respect the patient privacy and dignity of the patients in examining the patient in the side room or private examination room. But remember, always don't be alone with the patients. You have to have patient attendees or a witness from your side, a nurse or other doctor, in order to avoid embarrassing situation. Now, after we prepare everything for the patients, we have to start the clinical approach, or what's called the management. Yeah, the management generally started with history taking, and this is followed by physical examination. So, history taking will build up a list of differential diagnoses. General and systematic examination of the patients will shorten this list of differential diagnoses, and then investigation will point toward the diagnosis. It might reach to the final diagnosis. So the diagnosis is rely on the triad or the triangle, which is consists of clinical history, physical examination, and investigation. After we diagnose the patient, we should start treatment. And treatment could be medical or surgical. And after establishment of the treatment, we have to follow the patient, whether inpatient or outpatients, in order to watch the patient recovering and gaining back his or her health. And in addition to that, early detection of complication or late sequelae as early as possible. So, the diagnosis is really on history, physical examination, and investigation. And after the diagnosis, there's treatment, and after treatment is the follow-up. So, the whole process is called management. Is called management. So, if I ask you, how could you manage a case of abdominal pain? You have to take a history from the patient, to examine the patient generally and abdominal examination, then do certain investigation to reach the diagnosis, and then you list a differential diagnosis for each. You have to tell about the treatment and follow up for the complications. So going to be very long question. But generally, if I asked you how could you diagnose a case of abdominal pain, or how could you approach a patient with abdominal pain in order to diagnose, so the needed thing is the diagnosis. No need to tell about treatment or follow-up. Now, clinical history. The father of modern medicine, Sir William Osler, say, listen to the patient, he is telling you the diagnosis. So the word listen means listen to the patient's story, means take a history. And history is very important because the patients will tell you the diagnosis indirectly. So history is very important station toward the diagnosis. Now, the clinical history is consists generally from chief complaint and the duration. And the chief complaint is the main complaint make the patient asking for medical help. And this medical help could be got from a private clinic or primary healthcare center, emergency department, or outpatient department, consultation unit, and so on. And then the duration of that chief complaint. Try to be very precise in that point. After getting the chief complaint and the duration, then we will analyze this chief complaint in what's called history of present illness. So we analyze the problem, the current problem, in details in the patient ward. During present illness, you have not to use the medical term. So always stick to the patient word and listen to the patient a right way of present illness. So every single complaint should be analyzed in full. After analysis of the chief complaint, then we review the system. We review the systems, system by system, and you have a list for each system. So you should start with GIT, respiratory, cardiovascular, central nervous system, locomotor, and so on. So all systems should be reviewed for detection of a relevant symptom. Now, after mastering this review of system, then we took the past history, and the past history consisting of past medical history and past surgical history. And in the past medical history, we will concentrate on previous or current medical illnesses like diabetes mellitus, hypertension, in addition to hemoglobinopathies like sickle cell anemia, beta thalassemia, and so on. In addition to important medical problems that will affect the management plan in surgical ward, like epilepsy, bleeding tendency, and so on. So all medical past history should be reviewed, and the past surgical history again is very important, like previous surgeries, when does that surgery, what type of surgery, and any complication. In addition to accidents and blood transfusions, very important to be reviewed in the history of in the past history, followed by a family history. You know, certain diseases having a tendency to happen to run in the families, and many of surgical problem, again very important points in family history, like for example in breast cancer. So you have to give a surgical examples here, because you are concentrating on surgery now. For so many conditions, and the prototype or the famous example is the breast cancer. Social history again is very important. Social history consisting of social habits, in addition to the social habit itself. We concentrate on smoking and alcohol drinking, in addition to history of travel, and then in the social, the circumstances where the patient is living, details about the uh, home that he or she is living in, the crowding, and all of these informations having a clinical applications. So many diseases tend to occur in certain social conditions, for example, liver diseases and alcoholism, and certain occupations again is important. For example, sheep rearing and rural areas and its relation to hydatid disease and so on. This is going to be followed by drug history, and in drug history we will ask about drug allergies, we have chronic use of drugs, and in drug abuse. We will concentrate on certain drugs for drug allergy like penicillins and cephalosporin, in addition to sulfa drugs, because these are very common in our society to have allergy to these drugs, and it's important to mark the patient is sensitive to certain drugs. In addition to chronic use of drug, and these are very important because the patient is going to have a surgery and certain drugs should be stopped, certain drugs should be replaced, and generally we will ask about steroids, non-steroidal anti-inflammatory drugs, uh, uh, drugs that interfere with the normal coagulation, drugs that have uh, many we have many drugs that we can refer to like drugs that affect the metabolism of other drugs and so on. Now we will take an example which is the abdominal pain. Once you hear a patient with abdominal pain, then you have to have this picture in your mind. What's they call differential diagnosis of abdominal pain according to this side. So if the patient is suffering from upper central area, which is the epigastric area, and we have to have a very good anatomical information about this area. This area does contain the part of stomach, it is part of the liver, part of duodenum, again, abdominal part of the esophagus. So it could be a heartburn, hiatal hernia, again in the abdominal wall could be epigastric hernia, and so on. We will take another example, for example, right iliac fossa. And the right iliac fossa, we have appendicitis could be the cause, inflammatory bowel disease, constipation, and pelvic pain in gynecology because the tube, fallopian tube and ovary are located here. And the same thing is applied. So you have to have a very good information about anatomy. Then each organ could produce certain types of pain. Again, some information about abdominal pain in pediatric and even in adults. We have a medical cause and we have a surgical cause. So sometimes the pain is originated from medical condition like acute gastroenteritis, acute mesenteric lymphadenitis, urinary tract infection, gases, abdominal painful crisis in hemoglobinopathy, and so on. But certainly we will concentrate on surgical conditions like appendicitis, intussusception, acute cholecystitis, acute pancreatitis, urolithiasis means renal stones and urology stones, and abdominal trauma tumors, etc. So this is the typical curriculum for the history and usual cases, but we have a special cases in history taking. The first, we have two special cases. The first is what's called post-operative history. Post-operative history. There's a lot of changes happens on the classical history taking during post-operative time. And what is post-operative history? Back to our approach, we say there's a clinical history, physical examination, investigation leading to the diagnosis, and after the diagnosis, the treatment, and after treatment is a follow-up. This is the classical approach or management of a patient. So, if we have a surgical patient, we start with history taking, then examination, and then we will continue. But if the patient to start with is a post-operative case, so patient has a recent surgery, let's to say before 1 day or 2 days, so the patient is already have this management plan. There is some doctors take a history and do a physical examination and certain investigation done already, and the diagnosis is reached already, and the patient is treated surgically. So, and after this surgery, you come to the patient, and your mission now to take a history from a patient who had already diagnosed. Now, why we take a history from a patient already diagnosed and received the treatment? And that's the benefit, or that's the subject of post-operative history. So it is not logic to start history taking by chief complaint and duration like the patient without any surgery, firstly seen patient. It's not logic at all, but you have to start with a certain point that will benefit the patient in getting his post-operative course smooth, follow the patient and detect the early complication. So the main changes in the chief complaint and the duration. So for example, if the patient have appendectomy for appendicitis, so if the patient is already done surgery, which is appendectomy, and then the chief complaint going to be post-operative patient after removal of appendix, or even you can say after appendectomy, and the duration is the duration after surgery. For example, we say first day after removal of appendix, or day 1 after appendectomy. So this is the form of chief complaint. If you say abdominal pain for 3 hours before admission, this is false. Why? Because the patient is already diagnosed. And the post-operative history, chief complaint going to be the name of the surgery and the time post-operatively. Next paragraph of the history is the present illness. And the start of history of present illness is completely different. It is usually preferred to have 2 or 3 lines about a pre-operative condition, but the history of a present illness usually start from admission of the patient to the operative theater. That patient with appendicitis, when he was admitted at 11 a.m. this morning, and you come at night to take a history from him, then you have to say post-operative appendectomy few hours. This is called day 0 because the same day. And the chief complaint like that. What about the present illness? The present illness is going to start at 11 a.m. The patient is admitted to the theater. So the patient is admitted to the operative theater at 11 a.m. This is followed by how many time spent in the operative theater. And then after that, Does the patient need any blood during surgery? And these information going to be gathered from the patient attendants. And then, does the patient return to the same ward or to return to intensive care unit? This is very important. And after return, when the patient gain his consciousness, does the patient having a pain, and where is that pain? Whether in the sore throat because of intubation, site of surgery because of the incision, or other areas, for example, in the shoulder in cases of laparoscopy. Going to have irritation of the diaphragm and pain referred to the shoulders. So pain analysis is very important. Does the patient have any GIT symptoms like vomiting, nausea, sore throat, dysphagia? For example, after thyroid surgery, the patient having difficulty in swallowing. In addition to that, abdominal pain and so on. So analysis of GIT is very important. Then respiratory tract review is very important because general anesthesia will affect the respiratory symptoms, and there's many informations about post-operative respiratory complications, and every single candidate should be aware of that, like cough, chest pain, hemoptysis, and so on. So these are very important points in the post-operative history. These are points that make sense during post-operative history, in addition to certain things, for example, post-operative fever. And there's a differential diagnosis for post-operative fever in day 0, day 1, day 2, and onward. Another important thing is, does the patient start to mobilize? So early mobilization is advised in the majority of surgeries, thus to prevent deep venous thrombosis. So the majority of surgeries, after those surgeries, we ask the patient to start mobilize as soon as possible to prevent those disastrous complications. So post-operative history in the present illness is very important to review all possible post-operative complications day by day. So after finishing day 0, we go to day 1, day 2, day 3, and onward until reaching the day we are taking the history. And that's the importance of post-operative history, is to watching the patient's recovery, in addition to early detection of complications, and if there is a complication and we early detect it, that will decrease the morbidity and even the mortality of the patients. So we concentrate on post-operative rather than the pre-operative information. We don't forget to have a summary of a pre-operative condition in order to prepare the audience, the examiner, and to prepare our history to be fully understood by the person who will read it. So the first special case in history taking is the post-operative, and the second is taking history from victims of trauma and accidents. What is special for that is what's called the mechanism of injury. So we have to detect the mechanism of injury for every single victim of trauma and accidents. The mechanism of injury is very important, and at the same time is very easy. For example, if the patient having fall from height. So fall from height, we have to know the mechanism of injury. First of all, how high is that point from which the patient fall. Falling from half a meter is something, and falling from 2 meters is something else. In addition to that, falling from upstairs, how many steps in that stair? So 2, 3 stairs is something, and 10 or 15 steps is something else, because of multiple times the patient have a trauma to different part of the body until reaching the ground. So in cases of fall from height, we have to know what's the distance from the patient's fall. In addition to that, where is the point where the patient body face and meet the ground, because that will make important information. For example, falling from on the side of the body different from falling from on the head or on standing position, and this is very important for neurosurgeons, for orthopedicians, and even for general surgeons. Another example is, for example, car accidents. So for car accidents, you have to be sure about the mechanism of injury, whether the patient is in the road traffic accidents, whether the patient is pedestrian, is he walking in the road and some car hit him or her, or the patient himself is the driver, or he is a passenger in that car, where the patient is sitting. The driver is liable for certain injuries like fracture sternum and pericardial and cardiac contusions because of the steering wheel. In addition to that, the front passenger is liable for special fractures in the upper tibia, that's called dashboard fracture, because the acceleration of the patient is go upward forward after stopping of the car by the accident. But this doesn't happen in the passenger that sit in the rear seats, and so on. So mechanism of injury is very important. Mechanism of injury is very important in the history taking. So by this, I finish the outline of history. I know that history is very complex, but you have to make fine details on every point I mentioned, and I'm happy to receive your questions, and thank you.